Thanks, Grace. Welcome, everybody. Thank you for joining us. We got a lot of information to share with you today. You probably saw the message in the chat box that if you can, mute your phones. I know sometimes people get pulled away and they forget that they've left their phones open. So if you could do that, that would help. And we are really excited today to have our subject, which is going to be focusing on the reporting systems learning component of the hemorrhage bundle, and particularly looking at debriefing, post-events, and also huddles. And our speaker today is Ginny Wurttemberg. Ginny is a Georgia native and attended the Medical College of Georgia, where she graduated with her BSN in 1999. She doesn't look like that, as though she's been a nurse that long. After graduating, she worked as a labor and delivery nurse in Gainesville, Georgia. And then following her time in Gainesville, Ginny attended Vanderbilt University and obtained her MSN with a specialty in nursing delivery. While she was in nursing school, in graduate school, Ginny worked as an agency nurse in labor and delivery, high-risk antepartum and postpartum, so very well-rounded. And then following her graduation and on gaining her MSN, she practiced both as a nurse midwife and a labor and delivery nurse, but the majority of her time was spent at Northside Hospital. If that wasn't enough, in 2017, Ginny obtained a doctorate of nursing practice from the University of Alabama at Birmingham. And currently, Ginny is the clinical specialist for labor and delivery for the Northside Health System. And we're really pleased that Ginny offered to speak to us today about what was happening at Northside. So before you start, Ginny, I just wanted to let everybody know that, as you all know, or if you didn't know, we have CMEs for this session. It's one CME that is accepted by the Georgia Board of Nursing, so I do need to read a disclosure statement. The doctor's company would like to disclose that no one in a position to control or influence the content of this activity has reported relevant financial relationships with commercial interests. And the credit statement: the activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education, that's the ACCME, through the joint providership of the Doctors Company and Georgia Perinatal Quality Collaborative. The Doctors Company is accredited by the ACCME to provide continuing medical education for physicians. The Doctors Company designates this webinar for a maximum of 1 AMA PRA Category 1 credit, which again I mentioned is accepted by the Georgia Board of Nursing for nurses. Physicians should claim the credit commensurate with the extent of their participation in this activity. So I will hand it over to Ginny. Thank you very much, Ginny.
Thanks. Hey, everybody. I'm really excited to get to talk about the Huddles debriefs and multidisciplinary reviews, because any chance I get to talk to staff or whoever, I always feel like it just improves communication amongst our team. So I like getting to talk about that today. You can go ahead and go to the next. So I want to first start more on our staff level of why are huddles so important to our units? Because our huddles here at Northside are very important to just our team communication, for us to know what's going on, and for us to help one another. And honestly, one of the leading causes of medical errors is lack of communication or miscommunication, whether that be from nurse to nurse or nurse to a doctor. That communication is really important for the team to know what's going on with each of the patients, and so that we can provide them the care that they need, whether it be, this baby has D cells when she's laying on her left side and we need to flip her to her right side so the other team members can know this. It also really helps the team members to keep up with what's going on with everybody within their nurses station. We have pods at our hospital. We call our nurses stations pods. But this really helps our nurses to keep up, because, some days a nurse can be in a patient's, is somebody not muted? I just feel like I keep hearing something in my ear.
Yeah, I think we can hear somebody on their keyboard, so if you wouldn't mind muting, thank you. You can continue, Ginny.
Exactly what we're talking about. You can go on to the next slide. So what huddle recommendations do we really recommend? Well, first off, I'm going to start with our charge leadership recommendations. Your charge nurses should be huddling every shift. I don't know if everybody else does that, but I know that our charge nurses have a set time every single day where we meet to talk about what's going on. And it is a priority. None of the charge nurses are not there unless somebody is in a code or in a stat to where she can't get there that instant. Otherwise, all of our church nurses are already there, always there. And in fact, when we huddle with the charge nurses, unit leadership is there. The unit manager is there, clinicians come, I go to huddle. That allows all of us on the team to know what's going on. Now, I know at Northside Atlanta things are a little bit different because we're so big. And so for us, we have a huddle with just the different parts of labor and delivery, whether it be the labor patients, the charge nurse for the OR, our high-risk patients, or our supervisor for the day. But when I go up to Forsyth or Cherokee, their NICU charge nurse, their postpartum charge nurse, L&D charge nurse, high-risk charge nurse, and their managers all come. And so they really are able to know, they can see the big picture of what's going on. Next page. The charge nurses, I will go back and say that the charge nurses at Forsyth and Cherokee, it's amazing because they go through every single patient who's there and talk about when they expect them to deliver, if they have any medical history that's significant. That way the NICU can know if they have a baby that may be potentially coming to them after delivery. The NICU also talks about what sort of babies they have, whether they have anybody on the vent, if they're anticipating any discharges, how many open beds they have. That really allows us as a team to communicate better. Now, on the floor, our nurses are supposed to huddle every 4 hours. And I don't know if anybody else will chuckle about that because sometimes getting the nurses on the floor to huddle every 4 hours is hard because they're busy. I know that our nurses try very hard to do it every 4 hours as we expect them to do. And one of the big reasons is because our patients change so quickly. You know, one patient can have been fine for the past 5 hours and all of a sudden have spiked high blood pressures. Another patient that we all thought would have delivered still hasn't delivered at the end of those 4 hours. So this allows us to keep up to date with each patient who's on the unit. I was talking to another nurse who delivers at another hospital, and this is another thing. I don't know if any of y'all do this, but I found it to be a great idea. They, if they're having a patient they anticipate a shoulder dystocia on, or it's a twin delivery coming up, they talk at the nurses station at their huddle and say, okay, so if I call out for a shoulder dystocia, this nurse is going to come in and do suprapubic pressure for me. This nurse is going to come in and pull back leg. This nurse is going to call the nursery to make sure that we have the nursery at delivery. And so having some of these roles defined ahead of the time really does help the staff to really care for the patients the best they possibly can. Next page. Now, another thing that we're starting to try to implement at our hospital, and I'll be very interested to hear if any of y'all do anything like this, because we honestly read it in one of the AWON journals. I think we read it in Nursing for Women's Health. We're really trying to, in vivo, at that moment, review a fetal strip at the nurses station so that we can all make sure we're using the same verbiage, that we're all using those NICHD that NICHD terminology that's recommended. And so we'll just look at it and go, oh, would you call that a late? Would you call that a variable? Why? Less than 30 seconds, greater than 30 seconds, the baseline's the 135. No, you can't say 135 to 140. The baseline's 135. That truly allows our team to stay on the same page. And then the other thing about Huddles is we truly are able to discuss what challenges or concerns about patients, or just down to, hey, I can't get her reflexes and I'm really struggling. I feel like, her respiratory rate is fine, everything else is fine, but I can't get them. Would somebody else come and try? Maybe I'm just missing it. That's how we work as a team to care for our patients really the best we possibly can. Next page. However, we also have to throw in there, we have to think about the provider part of it, because unless you're a teaching hospital, which I don't know how many teaching hospitals we have on, but we don't have residents at Northside. We don't have, all of our docs are in private practice, so they are not standing around the nurse's station licking over strips with us all day, because they're doing surgery, they're seeing their other patients, they're delivering other babies, they're doing whatever. And so even though they are not at Huddles, we almost need to think about the communication with the providers as a huddle, and we need to do that regularly, because if we're not communicating with them regularly, then they don't know what's going on with our patients. One of the big things is we don't want to talk to the doc before he walks in the office and not have any other communication with him until he finishes his day. He should still get those same regular updates that everybody else gets, just so he knows the patient's status. Now, another thing with that provider communication is the effectiveness of it, using the correct terminology to tell them what's going on with their patients. Using the NICHD terminology instead of just saying, hey, your baby looks good, we're doing fine. You say, your baby has a baseline of 120 with moderate variabilities with positive accels and no decels. And she's contracting every 2 to 3 minutes, and her cervix went from 3 to 6. That gives the provider a lot more information to go on instead of, your baby looks good and she's contracting. Because we all know different people have different definitions in their mind of what contracting well is. And some people think contracting well is every 6 to 10 minutes. Other people think it's every 2. And so this allows us to have better communication with the provider during the labor. Next page. We do something, I don't know how other hospitals handle these situations, but I think we have a great interdisciplinary planning team here at Northside that we use if it's a patient at Forsyth or a patient at Cherokee or a patient who delivers in Atlanta. I would go as far as saying that the majority of these interdisciplinary planning teams occur because of patients who deliver at Northside Atlanta and not at Forsyth or Cherokee, but they do occur at these other places. When we have a patient who has a suspected accreta, percreta, or increta, we are going to have one of these planning teams. Sometimes we have very unique, sick patients who you think, wow, she's pregnant. Number one, that's a shock. But number two, she was diagnosed with cancer during the pregnancy and won't accept blood products, or has been diagnosed with cancer and isn't expected to make it through the procedure. Those different types of meetings need to be planned so that we can know how to best care for these patients, and make sure everyone is on the same level with what to do. Also, those patients who have the babies with conditions that are going to require special neonatologist at delivery, or if you're anticipating an exit procedure that needs to be done where they have to intubate the baby as soon as the baby's head comes out because you're worried about the fact that the baby's not going to be able to breathe if you don't do this because of different a neck mass or an enlarged thyroid to the point where it's blocking the airway. We have to have a plan on what to do for these patients. And our team really steps up to the plate. Next page. So on our interdisciplinary planning teams, we always have maternal fetal medicine, the OB, and then you go into what, and the MFM and the OB are going to be the leaders of this meeting because they're going, well, generally the OB is going to be the surgeon. So that OB is still the lead of it, even if someone else is sort of facilitating the meeting. But if you're concerned at all about the patient bleeding, and you might have gynonc there to say what sort of things that they want in the OR if they're having to assist. Anesthesia will come. Anesthesia will talk about, you know, we want to put an ART line before she delivers. I want her to have 2 IVs. These are the medications we need in the OR when this patient delivers. And our anesthesia always says, and do we have TXA? We want TXA in the room at delivery. You know, so as soon as our anesthesia likes to administer TXA on accretas and all soon after the cord is clamped and cut. If we're planning on having to use interventional radiology, they participate in these meetings. We have ICU, whether it be the intensivist or the ICU clinician, charge nurse, clinical specialist, whichever one of them will be there if we're anticipating a transfer directly to the ICU. We'll also have labor and delivery at this meeting. We'll have the antepartum if the patient's in the hospital and we know we want to get her prepared from antepartum to go to the to pre-op. The blood bank, we always have blood bank there so we can discuss what sorts of does anesthesia want the first pack of an MTP in the room, or what's the plan for blood and blood products for this patient. And then we also have nursing surgery there so that because they are going to be a part of this team, as well as pharmacy. We couldn't do it without all these people. Next page. And when we have these meetings, we talk about where this patient's going to deliver, because most of the time we don't want them delivering in labor and delivery ORs if we can get away with it. Who we need at the delivery, their blood products, the plans for blood products. If we need a second team because we're expecting issues with the neonate, if we need a second operating room because the neonate may need to be get a trach immediately after delivery. We plan all of these things so that we can make sure that when we go into that OR, everything goes smoothly, or as smoothly as we can control it. And that really helps a lot. Next page. Okay, so our post-procedure debrief, sometimes after some of these really unique C-sections that we have, we will have post-procedure debriefs immediately following the procedure to discuss what went well, what could have gone better, how we can improve things, any new processes, any problems the surgeons had or anesthesia had. But a lot of times, even though these ideally should be done immediately following the procedure, a lot of times we'll set up a meeting for a couple of days later when everybody can actually be there to sit down and review the case and decide what really worked and what didn't, so if in the future we have to do it again, we can do it even better than we did that time. Next slide. All right, so then we get into post-event debriefs, post-code debriefs. Those are always, your emotions are already ramped up. It has been a very stressful event because we all know we have, I can't say healthy people anymore because pregnant women used to really be healthy, and they're not as healthy anymore. But we still are in the happy area. We don't do codes or events, that are bad. We have babies, but we do have codes. We do have bad things happen. And we really have to debrief after these occur. We want these post-code debriefs to occur pretty much immediately following a code. The only problem with that is you want it to follow up right after the code, but the nurse who called the code is taking care of the patient, helping her get transferred to the unit. Somebody else is helping anesthesia, with all of their input and output. A lot of people are busy, so it makes it a little harder, but you need to at least get someone from each area to be represented at this debrief, because if you can at least have a pharmacy there and the leader of the nursing part from labor and delivery, and then the code team leads and whoever else, the house supervisor, all there, you can at least hit the high points of what went well, what you could have done better, if you should have given medication sooner, talk about your ratios of your blood packed cells to clotting factors. Those sort of things will help improve the next time we have a code, because we all know we have codes so rarely that if we have a post debrief on a code, we're going to remember what happened if we were there to help make another one go better. Next slide. This really is how we improve our processes, though. They don't have to take a long time, but you do need to confirm with your risk management department, because every hospital is unique in how they handle post-event code debrief type of situations as to what can be written down, if it's considered part of the medical record, if it's not considered part of the medical record, if this is considered protected information or not, since we sadly live in such a litigious society that we have to really think about that. So those are the other points that you really have to think about when you think about a code and a debrief is, what does your hospital system say is acceptable to do following that event? Next slide.
He'll be back in just a little
bit. So our hospital does something really neat that they just really started about 5 or 6 months ago, and I'll be interested to hear if anyone else does anything like this. We do something called swarming, and every single week, once a week, they meet, and every single code that was called the week before, they all come together in one day. So, and the leadership from whatever unit these codes were called on comes that day. So we can discuss the codes, what happened, and how our rapid response teams, our code blue teams can improve. Quality improvement's always there to talk about different ways we can continue to improve on our codes, what should have been called a code, what wasn't. And obviously labor and delivery doesn't get to go to many of those, but I've gotten to go to one, and it was very interesting to get the feedback from other units, because what we had wasn't even a code. But the feedback we got from rapid response and the code blue team really has impacted how we can manage patients even better. So swarming has been a neat way for us all to pull all the codes from that week together more efficiently than otherwise. Next slide. We also have a debriefing if there's an MTP. That has been that's newly been implemented at our hospital, and blood bank leads this debriefing because they are the keepers of the blood, But anesthesia, whatever anesthesiologist preferably who is involved in the MTP is always there. If you can get the physicians who were involved to come, they come. Nursing, leadership, clinicians will come, and we will review the whole process, the documentation, whether the runners stayed where the runner was supposed to stay, if the labs were taken back and forth to the labs appropriately, how communication occurred, and even down to let's look at the ratios of what did she get in packed cells, what did she get in cryo, what did she get in FFP or platelets. This really is improving everyone's thought processes on methods to be more efficient and give better care. And obviously, we also review the patient outcome in every situation with an MTP. Next slide. The CMQCC and the Council for Patient Safety and Women's Health and A1 all recommend multidisciplinary reviews. I would go as far as saying that this might sound kind of odd, but this is my favorite meeting of the month because I learned so much from it. Because the Multidisciplinary Review Committee really is just trying to identify what we can do better. And this is going to include anesthesia, OB, maternal fetal medicine, and nursing. Now, this is a closed committee, so it's not like it's just your normal OB meeting where anybody can show up. Only the people who are invited can come. It is confidential, and it really allows for some open communication. Next page. For us, and what is recommended is that patients who receive 4 or more units of blood, they are all reviewed in this meeting. And then patients who have an ICU admission are also all reviewed in this. Now, for us, we have chosen to review patients who have ICU admissions within 24 hours of delivery. So if the patient has had the flu and been in the ICU for 4 days, that may or may not be reviewed. But anybody who has been admitted to ICU since delivery is always going to be reviewed. Next slide. Now we have each case abstracted before the meeting, and all the cases are de-identified, so nobody knows what provider it is. Now, a lot of times you will because you may have been there, but you never say the name of the person, you never talk about. It is truly to look at what we can improve on, and if we see any areas that are consistently an issue where we can improve. This committee also makes recommendations for peer review and for practice changes. So there might be some recommendations for peer review, but this also helps you to say, oh, we might need to institute quantitative blood loss, or oh, do we need to institute a new hypertension order set? Those are the type of things that this committee is going to make recommendations for. Next slide. And then the last area I really wanted to talk about was a perinatal quality care collaborative. Basically, perinatal QI, methods to make our units better. We have a group that meets quarterly to talk about QI initiatives, patient safety, best practice, and everybody's there, from antepartum to labor and delivery, postpartum, the NICU, newborn nursery, lactation even comes. We cover everybody because we want to be able to see the big picture of every area. Next slide. This is where we present that QI data. This also really does help for us improve interdepartmental collaboration, communication, because even our Forsyth and Cherokee campuses are involved in this, so we get to hear their data and look at their data versus our data. So we see where we might be struggling and want to kind of pick up some of the things that they're doing or vice versa. So it's a really, really neat time for us when it comes to improving patient care and patient outcomes. Next slide. All right, but what about the staff nurses? Because there is so much data and there's so many steps that these QI initiatives have that our staff nurses need to buy into this, and they need to be a part of it, because if they're not, then they all kind of go, what are y'all doing now? What are y'all making us change? We don't even understand why. But if we can get these staff nurses involved and be able to champion some of our initiatives to improve patient outcomes, then we're going to have more staff owning it than what we would otherwise. And for us, we are really trying to motivate our nurses to participate in some of these initiatives as part of their annual goals. And this is just an easy way to push them right into it. Also, we have nurses who just want to be involved because they want to be involved, but they don't know how to be involved. This is a great way to make our staff nurses feel like a true part of the unit. Next slide.
You might want to fill that little piece out for the patient to take to the office to prove that they had it done. Then
there's staff.
So it's in.
Finally, we can, the way we can give this information to our staff is by telling about how to get involved, is we can do it in staff meetings. We can provide flyers at their annual evaluations for opportunities. We also have somebody on our unit who's actually coming up in the next week or two going to be sitting in the conference room just and having all the information about our different QI initiatives so that staff can come by and just talk to her and learn a little bit more about where they can be involved. So next slide. I think that's it, yeah. So thank you guys so much. I really appreciated getting to share this.
Thank you, Jeannie. That